Today we're going to be doing removing Joe's old gold bridge, going from tooth number 5, replacing tooth number 6. There's plenty of adequate jawbone on the facial. There's plenty of adequate bone on the lingual, so I don't predict any real problems. We suspect that there may be decay on the distal of tooth number 5, but we won't know that until we actually remove that gold work. So the patient has also requested that we replace missing tooth number 4 at the same time. So we're going to see if we can get all of that accomplished in one quick surgery. I'm predicting to do a flapless surgery. So we're going to remove the gold work. We're going to use a dermal punch to punch through the tissue and see what kind of bone and bone quality we have, and then we'll go from there. And just to confirm, Joe, you know you're being videotaped today, and this is going to be for educational purposes. Yes?
Yes.
Okay. Now when Joe first came in, the porcelain had sheared off the gold work, so we had done a temporary repair using composite and a bonding material. We opaqued out the metal and we repaired it satisfactorily, and it held for a few years. But now, just a few days before Christmas, of course, the whole thing gave way. So we're going to go ahead. First I'm going to re-prep tooth number 5 a little bit, just to see what that structure's like before I get in too deep. A little bit of decay on the distal. I'm going to come back and get that at a later time. That way we can temporize this tooth today and worry about that on another day, but the tooth is certainly salvageable. So we're going to go ahead now and make our punch. This device is from More Medical. It's a dermal punch, single use only, sterile. What we found is that we can actually melt and bend the handles of these really easily just using a simple torch, chair side, and we can use them at any angle. Really great for the posterior. You can keep them straight for the anterior. If we have a patient who can't open very wide, we'll even melt that and break that handle right off right at the top. Because they're single use, they're sterile, and they're extremely sharp right from the get-go. Now, if we get in there, we've discovered that he's got a very narrow ridge. I will do a full flap. Just going to remove that plug of tissue overlying the jawbone. Now I can tell just by feeling that that is really dense type 1, possibly borderline type 2 bone. Notice he's got exostoses almost everywhere, so we know that we're in denser bone. So we should get really good stabilization right from the get-go with our implant. All right, Joe. We're going to be using a saltwater spray, and you're going to get a little covered with this, okay, just because it's in the front of your mouth. Today we're using Hyacinth Surgical Kit. I love this kit. I love this system. The kit's very straightforward and simple, and then they have a great range of implants, everything from 3.5 all the way up to 7.0.
What are we doing? I'm so excited.
Okay, we're moving up. That was our last plunge cut. Now we're going to use a conical burr. These are depth cut so that they've got a stopper built in. You just follow your original plunge and down you go, all the way to the collar, and up you go and you're done. This is 3.5 right here. Now because he has such dense bone, I'm going to prep him out to our final size. I'm actually going to use, I normally don't, but because his bone is so dense, I'm actually going to use a little bit of a cortical drill here to take away a little more cortical plate. Just in the top. These implants do have a flare to them and taper, so I want to make sure that we accommodate that. I always hand driver my implant in. I don't use the the machine to do it because I want to feel with my fingers. I'm feeling at the apex to make sure that we have good bone stability. And that thing is binding up right there, and I can actually feel it pushing the bone away a little bit, which is great. So we're expanding the bone, and we're getting great stability. I've countersunk that about 3 to 4 millimeters. I'll probably come back with the laser when his healing is complete, and I will scallop that buccal tissue a little better. Even though on the other side his eye tooth actually doesn't have that much prominence. What's left now is just the carrier. So we're just going to unscrew that. Now I have found a problem with these carriers in the smaller sizes where they do tend to break off if you really torque on them hard. They'll break off in the top of the implant. That one came out clear. So usually we'll get them into a certain point and then we'll take this off, and then we have another way to get them driven to place. But that's driven in really nicely. This is the other driver. We take the carrier off and we can put that in place. That bottom ring is 5 millimeters, so we're at 4 millimeters of countersink on that. I'm about 3 millimeters below this gingival margin right here, which is absolutely perfect for an anterior tooth. So we got that done. We're going to go ahead and put a solid abutment on here. I'm going to contour that solid abutment a little bit, and then Michelle will make him a beautiful temporary for both of these teeth. And then Joe will decide whether or not he wants to go ahead and have the implant behind it placed. We're just going to put in that, it's a 4.0 rigid or solid abutment. You can see the angulation there. We did tilt that a little bit to the lingual or palate, which is great. And I'm just going to hand tighten that. I'm not going to over tighten that. And you can see what I was saying about possibly contouring the gums on the front with a laser and giving me a little more room there to work with. But for a temporary, this is going to work really well. Bite together for me, Joe. We got more room than we could ever ask for. So, all right. Now we're going to do the same thing with the back one. Again, we're going to use a punchless technique. Now you can see we have more ridge than you could ever ask for back here. It is dense bone. We have a digital pan on this, and we also have a periapical. He has about 15 millimeters of bone between this and the floor of the sinus, so I'm not worried about a sinus perforation at all on this. You got lots of jawbone, it's good. Just so everybody knows, me and Joe go way back. And we're going to remove the gingival plug on top. There we go. And again, just by taking my periosteal, I cannot make a dent in that bone. That is dense. That's going to be type 2 bone, where this was probably closer to a type 1. So, and I use my assistants to help me with my angulation. You'll hear me ask Michelle, open that so big, Joe. There you go. Lots of salt water, whether my angle's good or not. And she'll tell me go mesial, distal, lingual, whatever. Is that okay, Joe? Okay. I'm going to start a little more for the lingual. This one I'm going to go a little shallower. I'm going to use a 10 instead. The first one was a 3.5 by 11.5. This one we're going to go up to a 4.0 by 10. It's probably my most commonly used. 4.0 and 5.0 by 10s are probably my most frequently used implants in this office. You can just see the bone collection on that drill. You can collect that bone if you're going to use it for another surgical site. In this case, we're not going to use that. With this type 2 bone, I'm going to drill to the size that I want. I'm not going to under-drill. If he had type 3 or type 4 bone, type 3 bone, I would go at least a half a drill stop lower. If he's type 1 bone, I might even go 2 drill stops below what I'm going to do. Again, he's got pretty dense cortical plate, so we're going to go ahead and remove a little bit of that just to let that implant slide in there a little bit easier. Right. I'm not going to countersink that one quite as far. That's going to sit a little higher. And that's normally how I do them in the posterior anyway. Now you can notice the minimal bleeding that we have here. We're not going to be stitching at all. Everything will be nice and solved really nice there. This one I'm going to put a little bit of torque on it. Make sure it's seated all the way because it is in the posterior and I want him to be able to use this for function. Good. Okay. There we go. You can see now we've got 2 implants placed, bridge has been removed. We're ready to temporize all 3, and we did that in probably less than 15 minutes. All right, let's let Michelle do her business, and then we'll come back and we'll catch up later.